Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Bayer.
Hello, I'm Brooks Cash, the Dan and Lily Sterling Professor of Medicine at McGovern Medical School and Chief of Gastroenterology, Hepatology, and Nutrition at the University of Texas Health Science Center in Houston, Texas. Welcome to this program titled Case-Based Insights on Managing Constipation. Now, joining me today are these expert faculty. Amy Ledesky, Physician Assistant of the Digestive Health Institute at Northwestern Memorial Hospital in Chicago, Illinois. Joel Heidelbaugh, Clinical Professor in the Department of Family Medicine at the University of Michigan Medical School in Ann Arbor, Michigan. Diana Isaacs, Endocrine Clinical Pharmacy Specialist and Co-Director of Endocrine Disorders in Pregnancy at the Cleveland Clinic Endocrinology and Metabolism Institute in Cleveland, Ohio. And Mary Clark, Nurse Practitioner of the GI Motility and Physiology Program at UC San Diego in San Diego, California. Now, in this case-based program, we will cover the contributing factors for constipation, including medications that can cause constipation. We'll look at evidence-based over-the-counter therapy options for patients with constipation. We'll look at also appropriate lifestyle management to aid patients with constipation, and also how to incorporate shared decision-making when recommending over-the-counter treatment for constipation that is caused by pregnancy, medical conditions, or medications. Now, before we get to the cases, let's review the burden and effect on quality of life for patients with constipation. Chronic constipation affects up to 14% of people during their lifetime. It's more common in women, with about a 2.2-fold higher incidence in women than men. There's also increased symptom severity in the younger population. Of course, the occurrence of chronic constipation seems to increase with age. We see a higher prevalence as well as incidence in patients at least 65 years of age. And of course, we also see polypharmacy in older patients, and that can also increase the rate in those older patients and may impact the treatment efficacy and safety of some of our recommendations. Now, if we think about the negative impact of chronic constipation on quality of life, we can think of several areas of impact, such as emotional distress, interference with social activities. There's health anxiety or health worry that can occur because of constipation symptoms, and it also can impact relationships. We've known that for many years that constipation may be associated with depression, anxiety, and other psychosocial issues, and many patients accept that their symptoms result in physical and quality of life limitations. There's a general lack of awareness of many patients as well as practitioners in terms of treatments that can work for them and actually help their quality of life impairments due to chronic constipation. So let's move on to our first case.
Hi, my name is Amy Ledusky. I am a physician assistant, and I look forward to presenting on constipation in pregnancy. We will begin with a case study. Alina is a 28-year-old in her 18th week of pregnancy, which is her second trimester, and she presents to address constipation that developed towards the end of her first trimester. Her past medical history includes anxiety and hemorrhoids. She endorses having small, hard, pellet-like stools every 2 to 3 days associated with straining and incomplete evacuation. Unfortunately, this has resulted in a flare of engorged and painful hemorrhoids. She also reports debilitating nausea and vomiting during her first trimester, requiring frequent use of the anti-nausea medication ondansetron. She had to take it in order to maintain her hydration and oral intake, but she's relieved that the nausea has abated in her second trimester. Attempted constipation therapies over the past month include increasing dietary fiber and water intake. She is trying to use warm baths and witch hazel wipes to soothe her hemorrhoids. Current medications include sertraline 50 milligrams, which she's been stable on, and her prenatal vitamin with iron. She is feeling frustrated that preoccupation and discomfort with her constipation is impacting her quality of life when she was really hoping to feel better in her second trimester. Constipation is the second most commonly reported GI symptom in pregnancy, second to nausea, affecting one-third of women during pregnancy and postpartum throughout all 3 trimesters. In regards to quality of life, a study published in 2021 compared the quality of life in pregnant women with and without constipation, and there was a statistically significant difference in multiple variables impacting quality of life, including physical function, vitality, mental health, and social functioning. To some, constipation is considered a minor annoyance, but constipation in pregnancy and postpartum can lead to several debilitating complications, including severe hemorrhoids, glass cutting anal fissures, pelvic floor injury, exacerbation of anxiety and depression, anemia from severely bleeding hemorrhoids, as well as ER visits for fecal impaction. The development of constipation is a compounded multifactorial etiology. Progesterone-driven hormonal effects on gut motility leads to slow transit constipation in that first trimester, whereas the pressure effects from that expanded uterus on the rectosigmoid colon may cause obstructive symptoms in the third trimester. Furthermore, the hormone relaxin, which relaxes the pelvis and cervix during pregnancy, also decreases ileal smooth muscle contractions, thereby slowing small bowel transit. Other causes of constipation in pregnancy include antihistamines and antiemetic medications such as ondansetron, iron supplementation, which is a very common cause, the presence of other underlying conditions in pregnancy, such as hypothyroidism and gestational diabetes, a decrease in physical activity and exercise, and a reduction of fluid intake due to nausea and vomiting. Furthermore, we're learning more about the maternal gut microbiome and its changes secondary to hormones, diet, weight, and motility alterations. Additional risk factors for constipation with and without pregnancy include conditions such as polypharmacy, being on 9 or more medications, opioid-induced constipation, stress, depression, advanced age, low fiber diet, physical activity, and just being of the female sex. Let's circle back to Alina. Her risk factors for constipation include hormonal changes in pregnancy, painful hemorrhoids, the ondansetron that she's taking, as well as her prenatal with iron. First line recommendations for constipation with and without pregnancy include those lifestyle modifications. When we see Alina in clinic, we want to encourage her to focus on a well-balanced diet with fruits and vegetables and whole grains to try to meet 25 to 30 grams of fiber through insoluble and soluble fibers. We want her to be sipping on water throughout the day to maintain hydration, practice pregnancy safe exercise, practicing proper toileting behaviors, not ignoring the need to have a bowel movement, not sitting on the toilet for more than 5 minutes, pushing and straining, which could engorge the hemorrhoids. Using a technique, you have your knees elevated on a step stool, lean forward with your knees at a higher angle than your hips, elbows on knees, straighten spine. And that's the anatomical position to allow the pubal rectalis sling to relax and descend stool down. We want to caution pregnant women on antiemetics and iron supplements. If a pregnant woman does have iron deficiency anemia with severe constipation, maybe consider IV iron. Small frequent meals can be helpful, as well as adequate sleep. Here's a list of common over-the-counter therapies we will review. Fiber whether it's dietary or supplemental fiber, is generally considered safe in pregnancy. Psyllium is a robust, viscous, soluble fiber that holds onto water, creating a gel-like consistency. It's not easily fermentable by the gut bacteria, thus less bloating and gas. It can be used at 1 teaspoon to 1 tablespoon daily and can be increased up to 3 times a day. You want to encourage adequate water intake. Stool softeners, specifically docusate, is for very mild constipation. It's more of an emollient and is considered very safe in pregnancy. Osmotic laxatives are go-to when fiber supplementation is inadequate. Polyethylene glycol and magnesium-based laxatives, specifically magnesium hydroxide, are common osmotic laxatives. Polyethylene glycol is dosed at 17 grams, which is 1 capful, mixed with a cup of water. You can start with that once a day and increase up to twice a day. It's important to counsel patients that it can take a few days to build up in the system, and it's good to treat as well as prevent constipation throughout pregnancy, to prevent the postpartum constipation during that window of time at risk for more severe hemorrhoids and anal fissures. And it's safe to continue during breastfeeding as well. Stimulant laxatives, bisacodyl and senna, are also considered to be overall safe, unlikely to cause systemic toxicity. They're more for as needed use and to use them judiciously at the recommended dose of 1 to 2 tablets, ideally every 2 to 3 days is needed. Lubricants, castor oil, mineral oil, are not recommended in pregnancy and typically are not recommended for patients that aren't pregnant as well. They can also impact fat soluble vitamin malabsorption. We will return to our case study. Alina is now inquiring about what she can do next. What over the counter therapies are safe for her to use, as well as effective in treating the constipation she's suffering from during her pregnancy? During our appointment, we discussed some common approaches. We reviewed the soluble fiber psyllium, the osmotic laxative polyethylene glycol, as well as potentially that emollient, the docusate. Given the degree of the hard stools associated with her flare of hemorrhoids, we made a plan to start the polyethylene glycol at 1 capful a day, and pending her response, increase to twice daily. We said that it's okay to maintain on the polyethylene glycol through pregnancy, postpartum, and while breastfeeding. We counseled it could take a few days to find relief. I encouraged her to continue her prenatal with iron, as that's very important, but discuss that risk factor of iron-inducing constipation and to potentially discuss with her obstetrician, if needed, IV iron if her levels drop. With improvement in her nausea and vomiting in that first trimester, I encourage a limit the use of the ondansetron given its constipating effects. And I encourage ongoing lifestyle modifications. Continue eating a variety of high fiber foods, trying to reach that 25 to 30 grams per day, adequate hydration, safe exercise during pregnancy, and really focusing on those toileting behaviors of not ignoring the urge, avoid sitting for greater than 5 minutes. And obviously, with her flare of hemorrhoids, we need to treat that as that can lead to withdrawal and pain. So the sitz baths that she's doing, the warm water, adding Epsom salt, soaking 2 to 3 times a day, using the witch hazel wipes, and using occasional preparation H would be safe during her pregnancy. This concludes our presentation on constipation in pregnancy. Please proceed with the next chapter of this program.
Hi, I'm Dr. Joel Heidelbaum, a clinical professor in the Department of Family Medicine at the University of Michigan Medical School. Welcome to this Medscape presentation. This case is case number 2, constipation in a pediatric patient. So let's start with Gavin. And Gavin is a 10-year-old who recently started playing soccer for a competitive travel team, and he's very excited. One of the problems, though, is that he's been experiencing bloated stomach symptoms and told his mother he's basically having some quote unquote bathroom issues. So, this is actually a common scenario that we see in many of our pediatric patients. If you look at the prevalence of constipation, about 9.5% of the world's population of children suffer from chronic constipation. And most of these children actually live in non Western countries. So when we think about the term functional constipation, it's considered to be the most common functional gastrointestinal disorder in children. And there's a pooled global prevalence of about 14.5%. And if you were going to break this down on continent, Africa has the highest prevalence of constipation at about 31% reported, followed by America at about 12%, Europe about 8%, and Asia being about 6%. So globally, up to about a quarter of visits to pediatric gastroenterologists and about 3% of the general pediatric outpatient visits are due to functional constipation, common issue we see. So this schematic shows a world map and breaks it down very nicely in terms of geographical distribution of functional constipation by prevalence according to Rome 4 criteria for functional constipation. So let's highlight risk factors. What are the risk factors of constipation in pediatric patients? Oftentimes it can be stress, stressful life events, separation from a best friend, issues at school, whether it's being bullied or poor academic performance, change of school, lots of home related stressors, lots of things that kids are going to go through. Um, Divorce or separation from parents at home, loss of a parental job, loss of a parent, severe illnesses in the family. Any of these things can precipitate functional constipation in a child. It's also worthwhile to think about risk of maltreatment or abuse, including that in the history is imperative. Psychological trauma associated with abuse and maltreatment is commonly associated with functional constipation and other functional disorders. We think of psychological maladjustment, anxiety, depression, certainly worth screening for in our school age kids and in our adolescents. And we ask about parental rearing style, particularly during the time of toilet training. Were parents really strict about this? Did they give the child a lot of autonomy? Did they try to really push things along, perhaps earlier than the child was ready for? And certainly, parents with lower autonomy that neglected toilet training in kids, this can lead to fecal retention and constipation. So, poor toilet training early on is actually a major risk factor for the development of functional constipation in toddlers, which can carry over into school age children and adolescents. Other risk factors really include diet, and it's a common thing, certainly in history, to be able to elucidate typical diet of the child. If they're getting adequate fiber, certainly fruits, vegetables, grains. A low fiber diet is associated with constipation, as is consumption of fast food or high carbohydrate and certainly fatty foods. Cow's milk protein allergy is also a potential risk factor, and physical inactivity, sedentary lifestyle has been associated with functional constipation as well. There's a lot of attention toward the microbiome. And one of the things that's postulated is abnormal microbiota. So, the microbiome of the large intestine obviously plays a significant role in not only prevention of health and disease, but overall gastrointestinal motility and absorption. And increased Bacteroides and bifidobacteria in children with functional constipation is a prevalence thing. So there's no definitive evidence that the microbiome contributes significantly to predisposed children. But as we learn more over the coming years, we think this is going to be something worth our attention in terms of elucidating another potential risk factor. When we look at pathophysiologic mechanisms, early on, children may hold stool, and faulty toilet training, certainly painful defecation, not only creates but repeats that cycle of fecal holding. And painful defecation due to passage of hard or even large fecal masses is going to lead children to withhold stools. And what ultimately ends up happening is the rectal mucosa, which its job is to absorb water. The fecal mass ultimately becomes very hard and difficult to evacuate, creating that cycle of stool bulk, creating that cycle of painful defecation and difficulty with defecation. There can also be altered rectal compliance or certainly rectal tone. And In some studies, increases rectal tone has been associated with longstanding fecal impaction. So it's important to determine that as well, which can be which can lead to prolonged fecal stasis. Anal sphincter and pelvic floor dysfunction, often thought of in adults, not so much in kids, but certainly can be an issue as well. And so, if you think about what happens during defecation, the intrarectal pressure has to rise to a critical point that the sphincters relax and facilitate expulsion of stool. In some children with functional constipation, there's actually a paradoxical contraction, increasing that tone and creating a phenomenon where you're withholding stool to a greater degree. That increases intrarectal pressure, that increases stool holding times, it increases water absorption, it increases the stool becoming bigger and more bulky and harder to expel. And so the whole concept of this is really what's called dysenergic defecation. We also think about colonic dysfunction, and one of the main physiologic functions is to not only store but propel fecal matter as fecal matter goes through the entire colon and water is absorbed. So there are a number of different entities that can occur, or really myopathies, relative to impact on those cells or the inner lining of the colon, which we really think of as sort of like pacemaker cells, which could contribute to poor colonic transit when those are impacted. So, common symptoms in children. So, pain during defecation, lower abdominal discomfort due to impaction can be very troublesome. And associated with that, you can also have fecal incontinence, or you can have stooling around this massive amount of constipation. This can all lead to emotional and behavioral disturbances, maladjustment, chronic pain. This can worsen anxiety, it can worsen depression, it can create an avoidance of school and activities, and obviously impacts quality of life in a very negative fashion for children. It can lead to them not engaging with school, not engaging with activities, sports, etc. So, in one case controlled study, the researchers found that children with functional constipation have a lower health related quality of life than children with very severe organic diseases, such as reflux or inflammatory bowel disease. And that tells us really how severe this issue can be. In another study that was done in hospitals, and it was a case controlled study, it showed poor physical, emotional, social, and school related quality of life in children with functional constipation. So, how do we treat this? Well, the good news is that we can make improvements. We can make significant symptomatic improvements that improve quality of life for children. So, healthy dietary habits, certainly more fiber, less fast food, healthy lifestyle, recognizing and helping children to mitigate stressful events and situations are all worthwhile and are all proven in terms of increasing positive outcomes. So, in the treatment of constipation, we use both non pharmacological interventions such as education, dietary changes, talk about toilet training issues, behavioral interventions, even biofeedback and pelvic floor physical therapy, which has some good evidence in adults, can also be used in children. We also talk about pharmacologic treatments, including over the counter products such as osmotics and stimulant laxatives. And both pediatric patients and their families and caregivers can often be reluctant to incorporate pharmaceutical treatments when treating constipation, but they're proven safe. And even many of the over the counter treatments are very effective, both short and long term. So the goals of treatment for functional constipation in children are really across a few different phases. One is education, two is fecal disimpaction, three is preventing fecal reaccumulation, and four is ongoing follow up. So through education, it's important to think about adherence and increasing success and really being some positive force for the child so they understand that this can be normal and we can also help them through this. We addressed how it can be inconvenient. We understand and empathize how it can impact in a very negative fashion, not only school, but friendships and activities and quality of life. And we recognize the emotional impact of a lot of these symptoms as well. The second step is disimpaction, and there's several randomized controlled trials that have shown that polyethylene glycol and enemas are equally effective for fecal disimpaction. Another study showed that lactulose and polyethylene glycol successfully promote disimpaction and were safe. So polyethylene glycol and enemas are over the counter, lactulose is via prescription, but again, very safe, very easy to take and to use, and have been shown to improve symptoms even as fast as day 2 of treatment. When we look at preventing fecal reaccumulation and maintenance therapy, there are a lot of different treatments here. And this schematic shows a lot of options, looking at the agent, what's recommended relative to age, dosage, and side effects. I'm not going to read through all of this, but what's important ultimately is that the rectal laxatives and enemas, lubricants, the osmotic laxatives, except for lactulose, and the stimulants, all over counter and all easy to use, all very, very well tolerated. Um, and generally, most kids are going to respond even to the smallest amount or the smallest possible dose. Um, one common, there's several common side effects I'm going to highlight. And one you'll see in the schematic is rectal discomfort, which is listed for many of these. And really that comes just from the expulsion of a large stool mass. Sometimes diarrhea can occur, and that's probably common in the sense of increasing transit time up to the point where there can be a stool impaction. Abdominal cramping, sometimes nausea and vomiting, generally mild and self limited. Possible causes of traveler's constipation. So, again, going back to our case study, Gavin here, he's 10 years old and plays soccer and is on a travel team. So, oftentimes with traveling, what ends up happening is the toilet routine can be disrupted. And in kids, that may lead to holding or withholding. Hydration can vary, physical activity can vary. There may be anxiety related to travel. And there can also be limitations in terms of using laxatives as timing for bowel movements and routine hygiene practices may be unpredictable. So, going back to our case study, Gavin, 10-year-old, started playing soccer, competitive travel team. We've discussed a lot of different factors to understand his risk factors for constipation. And it all starts with taking a very important and thorough history to understand his past medical history, but also any psychosocial factors that may be contributing. Is there significant stress? Is there disruption in toileting that may lead to withholding relative to travel or relative to issues at school? And of course, there's a lot of options to help Gavin here, ranging from behavioral therapies to dietary therapies to safe over the counter regimens as well. So, thank you for your attention in reviewing this case. And we hope that this was helpful in treating your pediatric patients with constipation.
Hello, and welcome to case 3 about constipation and obesity. My name is Diana Isaacs, and I'm an endocrine clinical pharmacist at the Cleveland Clinic. So let's introduce our patient. We have Katrina. She is 32 years old. Her BMI is 33, putting her in the obesity category. She has had obesity for about 6 years. In terms of the medication she's taking, she takes citalopram for depression, that's an SSRI, and then she takes cetirizine for seasonal allergies. In terms of her lifestyle, so she is very sedentary. She does not have any regular exercise or physical activity regimen. She does work a desk job with little activity. So let's get into some background about obesity and constipation. And so I want to introduce this study that was from the NHANES database. And this looked at the relationship between body weight and constipation. This study included 11,785 people, and the overall prevalence of constipation was 9.42%. And the way that they define constipation in this study was less than or equal to 2 bowel movements per week. What they noticed was that there was indeed a link to constipation and elevated BMI. So when BMI was over 28, there tended to be higher rates of constipation. And in fact, when there was an elevated waist stature ratio over 58.3, there were also higher rates of constipation. And there was actually reduced rates of constipation in those that did not have central obesity. So, what this study concluded was that if for people that have lower BMIs, normal weight, and normal waist circumference, that there are lower rates of constipation. And those perhaps could be protective against constipation. Let's look at a little bit more data. So, this study looked at the prevalence of constipation in people with obesity. And so, this one's a little bit different. This study included 150 people, and the objective was to evaluate the prevalence of constipation in people that already had elevated BMIs. So, the BMIs in this study were actually over 35, and this was actually data taken from a previous randomized control trial. So the prevalence of constipation was much higher in this study. It was actually 24.67%, which isn't surprising since everyone in this study had obesity. But they did notice some trends. So, for example, there were higher rates of constipation in people that were younger. So, the 18 to 29 age group had higher rates. Also, those that were formerly smoking had higher rates as well. Interestingly, when they looked at some of these other trends like physical activity, water intake, intake of fiber rich foods, they actually did not find that there were higher rates of constipation, for example, in people that were not physically active or not drinking a lot of water or not having whole grain, having fiber rich foods, which is actually surprising because we would expect all of those would be protective. There was a trend in whole grains that there was a little bit less constipation in those that had whole grains, but not necessarily in those eating more fruits or vegetables. So let's go ahead and come back to our case, Katrina. So she is living with obesity, and her healthcare team goes ahead and starts her on a medication to treat her obesity. And so she is started on a GLP-1 receptor agonist, and the dose is titrated up. And now she's been on it for 3 months. So she's gotten to like that third highest dose. And we ask her about her bowel movements, and she's reporting that she has bowel movements about 1 to 2 times per week, and she's having incomplete defecation. So she really is meeting the definition of having constipation. So let's explore this a little bit more. How are GLP-1 receptor agonists related to constipation? So they are known to have effects on the stomach, intestines, exocrine pancreas, gallbladder, and liver. And these effects are dose dependent. So some of what's happening is there is reduced gut motility. There is that slowing of gastric emptying. This can lead to reduced food as well as water intake because many patients will say, well, they're just not hungry, and when they're not hungry, they're also not necessarily taking in as much liquids and as much water. Most of the GI effects that occur from GLP-1 agonists tend to occur within the first month. And what you're seeing here is a combination of events that have been reported to the FDA and the time to onset. So, looking at, well, how many events are reported in the first 30 days compared to the first 60, 90, and so on. And what we see is that most of these events are occurring in that first month, in the first 30 days. 15% of events of GI side effects are occurring. But once that 30 days has passed, the onset of new events is much, much less. Even that second 30 days, that 30 to 60 days, it's down to 1.41% of new events. And we see that ongoing new events, that percentage is very, very small. Well, what are the most common GI adverse effects? So I know that we are here today talking about constipation, but constipation is not the only adverse effect that can occur. We also can see diarrhea. And in fact, diarrhea and constipation can both occur somewhat equally. Some people will experience constipation, others will experience diarrhea, and in fact, both can occur within the same person. In addition to that, we also commonly see nausea, and when nausea gets badly enough, that can lead to vomiting, and also abdominal pain can occur as well. Some of the more serious, much less common side effects could include gastroparesis. And then pancreatitis has never been proven to be directly related to GLP 1s, but we certainly see that some of these events are reported. One thing is that when we do compare different GLP-1 agonists, which many times they're not compared directly to each other, we see overall common rates of these adverse effects. Sometimes they're different from study to study, but generally we see that overall they have similar adverse event rates, although sometimes one person may experience one drug have less side effects compared to another drug. What about tirzepatide? So the previous data was looking at semaglutide and liraglutide and dulaglutide and exenatide. But tirzepatide, what about that? So the previous study didn't include that because it only went through 2022. In the Surpass 2 program, that actually studied tirzepatide directly to semaglutide. And so here we get a breakdown of these common adverse events. And specifically, when we look at constipation, we see that the tirzepatide 5 milligrams had a 7% rate. The 10 and the 15 milligrams had a 5% rate in that trial. And then the semaglutide 1 milligram had a 6% rate. So overall, very, very similar findings when we compare the two, semaglutide to tirzepatide. Well, what exactly is happening here? And why do some people have constipation and others actually have diarrhea? So, when it comes to this mechanism, it is definitely promoting satiety in the brain. And this leads to a decreased appetite. So, when a person is eating less, naturally, there is going to be less stool that is formed. In addition to that, within the upper GI, there is there is a decrease actually in gastric motility, and there's a decrease in gastric emptying, and then an increase in gastric distension. Within the lower GI, it's very similar as the upper GI, but to a lesser extent. Now, lifestyle and dietary modifications are definitely going to affect what is going on as well. So, if a person is eating less fiber, if they're not as hungry and they're not eating as many whole grains and as many fruits and vegetables, then that can affect their stools. Also, adequate hydration. And then physical activity as well. If a person is not as physically active and not moving as much, that can affect the consistency or the frequency of their bowels as well. When it comes to exercise and hydration, the data is very mixed. So, of course, we want to encourage people to exercise. And logically, it makes sense that if someone is moving more, that their insides are going to move more and it would be easier to defecate. However, the data is mixed and it's not always clear necessarily that increasing exercise will improve constipation. That being said, exercise does improve quality of life and it has so many other benefits. We definitely want to encourage it. Drinking water also by itself doesn't necessarily improve constipation. However, if someone is not drinking enough water, then drinking at least the recommended amount will help. But if someone is already drinking, for example, 2 liters or more per day, drinking more water may not necessarily help with their constipation at that point. Now, what do the guidelines say? So, the guidelines say that for primary chronic constipation, we definitely want to emphasize healthy lifestyle. So, having adequate fiber intake, supplementing with fiber is needed if the diet doesn't have enough high fiber foods. They do recommend regular exercise, and then they do recommend a variety of stool softeners, bulk laxatives, foods like prunes, kiwi fruit to help with that constipation. If a person is not responsive, the next line then would be osmotic laxatives. So things like the polyethylene glycol or lactulose or magnesium containing laxatives. And then if someone's still not having bowel movements, especially in 3 days, using what's considered to be rescue therapy stimulant laxatives. So those would be things like senna or bisacodyl. And then if it's still refractory, then we have to look at some other additional therapies or perhaps other causes that are happening to lead to this. Now, with all of this, let's come back to our case, Katrina. So remember, she was started on a GLP-1 agonist about 3 months ago, and she is experiencing constipation. So there's a few things I'd like to do here. I always like to review the medication list and see if there's any causes of constipation in the other medications. So she's also taking citalopram and cetirizine, drugs not typically known for causing constipation. And I would, of course, evaluate, we should assess prior to starting the GLP-1 if she had constipation. Assuming we ask her she did not have it prior, it's likely those are not the causes. Although that other study did report that polypharmacy, people taking 5 or more medications, have higher rates of constipation. In this case, she's only taking 3 medications. So I would want to counsel her on lifestyle, right? So she was not very active and she continues to be very sedentary. So ideally, prior to starting the GLP-1, I want to emphasize healthy eating. I want to emphasize regular physical activity with a goal of 30 minutes, 5 or more days a week. Also incorporating strength training, because as people lose weight, they can also lose muscle mass as well, and emphasizing these rich in fiber foods. So having whole grains, having fruits and non-starchy vegetables. That would be my first approach. Also asking her how much water she is drinking and emphasizing to drink plenty of water. And then if that is still not effective at that point, then we can start looking at some pharmacotherapy. And so my first would definitely be considering some fiber supplementation. If that is not effective, then we could start looking at additional therapy. But I think that in this case, there's so much that we can do with lifestyle. And ideally, we would provide this education at the beginning. But we know that sometimes it doesn't happen. And so at least providing that at this visit, and we may even hold off on escalating the dose further to just make sure that this side effect is resolved before increasing the dose even more. So that wraps up Katrina. Thank you so much for listening to this case presentation.
Hi, my name is Mary Clark. I'm a nurse practitioner in Southern California in gastroenterology, and today I'm going to talk to you about constipation in menopause. We're going to start with a case study. This is Anna. Anna's a 52-year-old woman, married for 30 years. She has 2 children, and she's a full-time occupational therapist. She meets the middle class socioeconomic status. Menopause for her started around age 48. She's had no menstrual periods for the past 10 months. With menopause has come some vasomotor changes, hot flashes, night sweats. She also noticed constipation. In the past few years, her stools have gotten harder. She's having more difficulty being able to evacuate her bowels, feels incomplete defecation, and having to strain to defecate. She also notices some mild bloating, but this improves after her bowels move. She's got no history of GI disorders. She's had a few surgeries, a LASIK eye surgery, as well as a knee surgery. Her social history includes she's a non smoker. She drinks about 3 to 4 glasses of wine a week, no illicit drug use. She played college sports and maintained an active lifestyle, but has slowed down in the past few years. So, before we dive into constipation and menopause, we're going to look at the definition of functional constipation according to the Rome Foundation. This is a foundation that creates or sets up diagnostic criteria for GI disorders that are functional. We look at functional constipation as defined as at least for the past 6 months, with meeting criteria in the past 3 months of 2 or more of the following: having fewer than 3 bowel movements a week, and 25% or more of these are hard and lumpy stools, straining to defecate, having that sensation of incomplete evacuation, a sensation that there may be this anal rectal obstacle or obstruction or blockade, and sometimes patients are having to use manual maneuvers to evacuate their bowels. This differs a little bit from irritable bowel syndrome, which meets that criteria, but there's also this visceral hypersensitivity or abdominal pain or discomfort associated with defecation. There's other types of constipation, such as slow transit, where it takes a long time for stool to move through the colon, and patients often say they just don't feel that urge to defecate. There's also outlet constipation or dysenergic defecation, where the anal rectal muscles are not coordinating or they may not be strong enough to help completely evacuate the bowels. And then opiate induced constipation, just as it sounds, it comes from taking opiates, which slows down motility throughout the GI tract, including the colon. When evaluating a patient for constipation, you always want to make sure you're evaluating for alarm symptoms. These are such things as noting blood on the tissue, blood in the toilet. On labs, you can find some iron deficiency anemia, unintentional weight loss of at least 5% in the past 6 to 12 months, a new onset of unexplained constipation, not quite sure where this is coming from, but all of a sudden they've noticed these acute changes, and any obstructive symptoms where they're just really not being able to evacuate a bowel. Sometimes patients will complain of a ribbon-like stool where it's very flat. And those are concerning because you always want to make sure the patient is up to date on their colorectal screening. So for colonoscopy screening starts at age 45 to evaluate for colorectal cancer. The American Gastroenterological Association 2 years ago updated their guidelines and they changed the age from 50 to 45 in response to the increased incidence of early onset colorectal cancer. This aligns with the American Cancer Society's 2018 recommendation that they also believe that screening should start at age 45. So looking at Anna, we've gotten some labs. Her thyroid is normal because that can affect bowels. Her CBC is normal, so not detecting anemia, and she also has a normal calcium. She's had no real change in stool caliber, so they're not getting smaller, and denies any rectal bleeding or hematochezia. Her last colonoscopy was 2 years ago. She's up to date. That was at age 50, and no detection of polyps. So she had her colonoscopy at about the timing 2 years ago when the criteria had just changed. She also notices a 5 pound weight gain in the past year because she's been more sedentary. So she does not have that unintentional weight loss. There are several factors that can affect functional constipation. Age can be a factor, the female gender can be a factor, physical activity, a low fiber or low calorie diet can also have an impact on constipation. Low socioeconomic status. Sometimes this is access to healthy food that can impact a patient's ability to move their bowels. Polypharmacy. As we age, taking multiple medications can have this overlapping effect where patients may notice that they're having more constipation than they used to have. Stress can be a factor as well as depression. So, as we look at the major risk factors in the scenario of a patient with constipation and menopause, age is a factor. Being female, because there's 2-to-1 ratio of male versus female as far as constipation, and then stress also plays a role. What are the menopausal changes that can lead to constipation? Well, there's several hormonal changes that occur. Estrogen tends to drop during menopause, and this can result in the slowdown of movement of stool through the colon. Estrogen helps to regulate fluid balance. So, as there's this deregulation, this can lead to dehydration and subsequently lead to constipation. Progesterone also can play a role in motility and can lead to slower transit of stool, resulting in hard stools because the longer the stool stays in the colon, the more water is absorbed from the body from the colon that can result in harder stools. Also, looking at constipation, there's been some studies that suggest that it's not necessarily directly related to estrogen and progesterone, but more that when estrogen is low, cortisol is high. And cortisol is that stress hormone, our body's response to stress that becomes more sensitive during menopause. There's also anatomical changes. The pelvic floor tends to relax over time. There's less collagen to support the pelvic features. And particularly if a patient has had children, particularly vaginal births, they can affect the pelvic floor muscles. And this doesn't happen until decades later, where patients start complaining in their 50s or 60s of incomplete defecation, whereas they didn't notice it right after childbirthing. Rectal prolapse can also play a role since there's a blockage and incomplete defecation. So there's some lifestyle factors in menopause that can affect bowel function. Fatigue happens with menopause as these hormones shift. This can lead to reduced activity, which can subsequently lead to slowing down bowel movements. There's some studies that looked at mobility that improves motility, and this supports the notion that staying active can increase blood flow and can produce and improve motility in the colon. There's several medications that can contribute to constipation: opiates, calcium channel blockers, anticholinergic medications, things like antidepressants and iron supplements could all play a role. And if patients are taking multiple medications that fit into those categories, they can have that compounding effect. There's other comorbidities that may emerge in the menopausal age group, things like Parkinson's disease, scleroderma, diabetes, and then going back to that opioid use, the chronic pain resulting in need for opioid use, and also with chronic pain, the decreased mobility. So, ways to relieve constipation during menopause: making sure that patients are taking enough fiber, getting enough fruits and vegetables and whole grains and legumes to ensure there's adequate fiber in the diet. The CDC recommends about 22 to 34 grams of fiber a day, and you want to introduce fiber slowly. So, advancing fiber by maybe about 5 grams a week to see how it's tolerated in order to reduce bloating that can be a side effect of too much fiber. Good hydration, drinking water throughout the day to prevent dehydration because this can worsen constipation. And then having patients exercise regularly to help stimulate that digestive system and promote a good bowel movement. The recommendation by the CDC is to exercise 30 minutes, 5 days a week. So, looking at over the counter remedies for treating constipation, you can start with fiber as an initial therapy. Looking at patients' dietary history and how much dietary fiber they're currently consuming can help establish goals for increasing fiber intake. Fiber supplements can be used as a first line therapy, particularly in those patients who have low fiber intake. Among fiber supplements, psyllium tends to be a good option, as this is a soluble fiber that turns stool into gel and makes it easier to pass. Making sure patients have adequate hydration when they're consuming fiber can also be helpful. One of the downsides of fiber is that flatulence is a common side effect. So, again, reminding patients to introduce fiber slowly and taper it, and also finding those fibers foods that are tolerable for patients. Looking at a study that recommends use of kiwi as a fiber source for some patients has become very effective, can increase bowel frequency and reduce that side effect of bloating often found in psyllium. Other recommendations, and these are by the American Gastroenterological Association, are osmotic laxatives. These are things like polyethylene glycol that have a strong recommendation and some good evidence to support it. Polyethylene glycol can be used in combination with fiber or as a monotherapy. The benefits of polyethylene glycol is this is a powder formula, so it could be titrated and individualized to a patient's need. Usually, we have patients start with a half capful and they can titrate up to a capful and a half. And in clinical studies, this is about where most patients landed for the best efficacy is a capful and a half per day. Other osmotic laxatives include magnesium oxide. This did not have such strong recommendation, but still can be effective. In patients who take osmotic laxatives such as magnesium, they need to be careful with if they have kidney insufficiency because this can increase their risk of hypermagnesemia. This should be titrated slowly. And for patients who have difficulty sleeping, if they're going to take magnesium, it's recommended they take it at night. There's stimulant laxatives like bisacodyl. These are good for short-term use. These will stimulate the bowels to move, and so using these more as a rescue instead of a regular therapy is often recommended. This also includes over-the-counter medications such as Senna. Of the two, bisacodyl has a higher level of certainty of evidence and strength of recommendation. Know that when using laxatives, even over-the-counter laxatives, side effects can include cramping, abdominal pain, and diarrhea. So patients are cautioned to again titrate these slowly. So looking back at Anna has started to implement some of these changes. She's been increasing her fiber in her diet through psyllium, but this did cause bloating. She started walking 10 minutes a day, 5 days per week, and has gradually increased her activity to 25 minutes a day, 5 days a week. She's found things such as listening to music and walking with a partner being helpful, making walks more enjoyable and less risk of that spike of cortisol that can contribute to constipation. She increased fiber through dietary changes, slowly adding fruits and vegetables, including 2 kiwi a day. She did start on polyethylene glycol, starting with a half capful a day, and has titrated up to 1 capful a day. She now has regular bowel movements. They're soft and formed. She's noticing less straining, and bowels are moving at least 3 days a week. And she's satisfied with this regimen. So, in conclusion, using multiple lifestyle modifications in addition to over the counter laxatives can help menopausal women transition through the changes and help to treat constipation. Thank you for listening.
So, what we've reviewed today is causes of chronic constipation and constipation in general in adults and children. Remember the risk factors that we talked about, including older age, female sex, physical inactivity, low fiber diet, as well as low calorie diet, and polypharmacy. There's also input on stress as well as depression on chronic constipation and constipation symptoms in general. And don't forget those special circumstances such as pregnancy and increasing use of medications such as GLP-1 inhibitors. Now, remember, for early and easy treatment of chronic constipation, we start with hydration and fiber, generally soluble fiber, at least 1 tablespoon or 10 to 15 grams per day. We also should encourage patients when they can to increase their activity level. Appropriate exercise can help patients with constipation symptoms. And of course, we have to remember in our special populations, such as pregnant females, that safe exercise is important to keep in mind when we do rate that recommendation. If we can help patients reduce their stress levels and understand their symptoms and also deal with their symptoms more effectively, that can play a big part in the treatment of constipation. And sleep hygiene, increasing sleep and relaxation can also help with constipation symptoms. We also talked about OTC or over the counter therapies for constipation. There are several over the counter therapies that are considered generally safe during pregnancy. However, studies in this area are limited. Now, the medications that are considered generally safe include psyllium, which is a soluble fiber, as is calcium polycarbonate, and then osmotic laxatives such as polyethylene glycol and magnesium hydroxide. There are also several over the counter therapies that are approved to treat constipation in children, and these include rectal laxatives such as sodium phosphate and saline enemas. Mineral oil lubricant is approved in children over the age of 1. Now, osmotic laxatives such as polyethylene glycol, magnesium hydroxide are approved for use with children, as are various stimulant laxatives. It's important to work with our patients and employ shared decision making. You've heard about 4 unique cases of patients who are experiencing constipation, and each case resulted in unique recommendations to treat that constipation and those constipation symptoms. It's important to understand each patient's specific concerns and values regarding how they want to manage their constipation symptoms. For example, increasing exercise may not be a realistic option for some patients. Treating comorbidities such as hemorrhoids might lead to different recommendations. And when we treat a child with constipation, it's important to include the child and or the caregivers in the decisions about recommending OTC treatments as well as lifestyle recommendations. The ultimate goal is to improve symptoms as well as the quality of life of these patients.